Ahead and get started. Welcome, everyone. I want to welcome everyone to the webinar. For those of you who don't know me, I am Dr. Lauren Levine. I am your host and moderator. Another great turnout, as always. We have close to 600 people registered. Fantastic turnout, based, of course, on the speaker and the content. As always, I hope that everyone's staying healthy and safe out there. I commend you for being here this evening, continuing your dental education. As typical, I'm only going to speak for a couple of minutes. I want to just do some housekeeping. I want to make sure that Dr. Schlesinger can speak for as long as he needs. And he had mentioned that he really wants to leave time at the end for questions. Most of you have been on these webinars in the past. So you kind of know the format. Our speaker usually goes for 45 minutes to an hour. We don't do verbal questions, obviously, when we have 500-600 people on. But on your screen, you have a GoToWebinar control panel where you can just type in your questions as you think about them. We typically can get to all the questions, but I never know. Sometimes we just have a couple of questions. Sometimes we have dozens of questions. I will do my best to get to all of them. We don't have a hard stop at any point, but we want to be respectful of Dr. Schlesinger's time and as well as your time as well. In the next few days, look for a couple of things. First off, the webinar, as with all the webinars, is recorded. So you will be emailed the link to download that recording. It usually takes a couple of days, so don't worry if you can't make it to the end or you get distracted. During the webinar, Chuck's going to show some products and systems that he uses, which are exclusive to GoldenDent. I've been working with Kurt and Jason and the GoldenDent folks for well over 10 years. We thank them, as always, for sponsoring the webinars. They're the ones that are bringing in these excellent speakers and working with them to develop the content that we think is going to be valuable to everyone. We always get a number of questions about CE afterwards. I'm going to try to mention it at least a few times this evening. Basically, there's nothing you need to do. We track when you logged in because everyone was sent a unique link. If you just called in rather than click the link, that there's no way for us to track that. And plus, it's a live, PowerPoint presentation. You got to be able to see the screen. So once you click that link, we log when you logged in, we log when you went out. As long as you were here for the bulk of the webinar, then you will be sent the CE. There's no quiz or registration or anything like that. When you log out, when you're done, you're done. And that can take a little bit longer because they have to go through the report and then see who was here long enough and customize it and send it off to you. So it's not uncommon for that to take about a week or so. Keep an eye on your junk folders because sometimes it ends up there. If you don't have it, I'd say by next Wednesday, a week from tomorrow, feel free to reach out to me and I'll follow up with Kurt and all the GoldenDent folks to get on top of that for you. So with that out of the way, I am thrilled to introduce Dr. Charles Schlesinger. He is currently VP of Clinical Development at Implant Ltd. and an internationally recognized dental implant practitioner and educator. He graduated with honors from the Ohio State College of Dentistry and completed a GPR at the Veteran Affairs Medical Center in San Diego, later serving as chief resident at the Veterans Affairs Medical Center in West LA, where he received extensive training in oral surgery, implantology, and advanced restorative care. He maintained a thriving implant and restorative practice in San Diego before moving to Albuquerque to lead education and clinical affairs for a dental implant manufacturer, eventually serving as their COO. He later returned to private practice, founded the C.D. Schlesinger Group, LLC, and became COO of Comfortable Dentistry for You while continuing patient care. He is a fellow of the ICOI and has lectured internationally for over 20 years. Chuck, we're looking forward to the presentation. I'm thrilled. I was a former periodontist. I think this is a great topic, and take it away. Are you there? We can't hear you, so I'm not sure what's going on with your mic. I can see your screen, but I can't see your microphone. So I don't know. Did you want to maybe try to take out the AirPods? Okay, so we can actually see it. Yeah, so we're seeing everything, but I'm just not hearing you. So this is the joy, everyone, of running the live webinars. You never know when there's going to be problems there. Chuck's mic was working perfectly fine up until until now. So I'm not sure what's happening here, but we'll get this figured out. So please bear with us for a minute and we'll get this resolved.
All right, can you hear me now?
We can hear you. Go for it. Yeah.
All right.
Yeah, we get a little feedback because I know you're on your speakers, but that's okay. I'm gonna mute myself and you take it away.
All right. Let me just make sure that everything else is off. There we go. Okay. So again, thank you. Thank you so much for everybody taking time out this evening to listen to me. We're going to talk about socket preservation utilizing composite graft plugs. I'm going to get into a bit of science here also, and I think that that's good because I think it's always good to know how products work and the downsides to some of the products that we have out there, so you can make informed decisions for your own clinical use. And without further ado, I'm going to go ahead and move on here. As was said earlier by Lauren, I am an employee of ImpluDent Limited as the director of clinical there. And so what we're going to do is jump into things, and you probably see it in your own practice. And depending upon where you practice, what part of the country, you may see more, you may see less. But for the most part, there is a lot of teeth that are being extracted every year in this country. And socket preservation is a huge, huge part of what is being done out there outside your office or maybe within your office. And I know that sometimes when we are solo practitioners in an office, you don't really know what's going on out and around you unless you are paying attention to not only continuing education, but periodicals out there. But you know, if you are not preserving your sockets or doing alveolar ridge preservation, it is something that you need to do because the benefit is multifold for not only your patient but also for yourself. You know, without grafting, what has a tendency to occur is we get a tremendous amount of bone loss, depending upon where in the mouth it is, depending upon why the tooth is coming out. It is very possible to have 30 to 60% of bone volume minimized over a 2 to 3 year period after extraction. And that becomes a problem. It becomes a problem for us when we want to place implants. It can become a problem for us when we're just trying to do conventional fixed prosthodontics. And so if we can prevent this from happening, then it's a win-win for everyone. You know, there's huge advantages of grafting at the time of extraction. And when I have my discussion with my patients, this is one of the things that we really go over, because I always present that we're supposed to do or that we want to do grafting along with our extraction. And sometimes patients don't really understand the reason why. They just look at it as, well, it's another expense. And so what we do is we sit down and we talk to them about the fact that we can lose bone height and how not only can that affect the area where the tooth comes out, but it can also affect the teeth on either side of that extraction site. By grafting at the time of extraction, we can prevent periodontal issues. We can prevent recession around teeth. You know, many times a side effect of an extraction is that the teeth on either side end up with some thermal sensitivity, and that thermal sensitivity comes from the fact that we have a decrease in bone height, which then decreases the soft tissue level, and then we have exposed dentinal tubules or to expose cementum that is going to be sensitive. So we kind of explain to the patient that not only are we taking care of the problem and we're going to get that tooth out that's bad so it doesn't become a bigger problem. But then we also should do something in order to prevent and then to set us up for success in the future, depending upon what kind of restoration they want, whether it be an implant, whether it be a fixed bridge, whether it be a removable partial. Any of those things will benefit from us maintaining that bone. We've all seen patients like this in our practice, right? We see vertical or horizontal defects that occur when we take a tooth out and we might have a dehiscence and we haven't really identified it. We get bone that the buccal plate just melts away if we haven't damaged it by extraction. And in extreme cases, we can get big changes in vertical height also. And then as you can see on the patient on the right, that can be a very difficult situation to restore, whether it is implants or a conventional fixed prosthesis, because now we're going to end up having either extremely long teeth or we're going to have to use a bunch of pink porcelain in order to mask the problem. The other option that can occur that we tell these patients is that you don't do grafting at the time of extraction. It may set you up for a situation where you're going to need to do a ridge augmentation later on. Both of these cases could be repaired with a ridge augmentation, and this becomes a very not only time-consuming but expensive procedure for the patient. So we try to set them up for success from the very beginning, and then that also has a self-serving aspect to it because it makes my job easier when I have to come back and I have to restore this. So we know that alveolar ridge preservation works, and you know, when you look at it, that it decreases the amount of additional grafting tremendously. This is a huge advantage, and prevents us from having to deal with complications that make additional treatment very difficult. But we also have to remember that even if we do graft, we cannot stop some of the dimensional changes that are going to occur. We are going to get some degree of ridge collapse, but as I said, we're going to get much better outcomes than if we allow the body to go ahead and try to heal unassisted. And that small amount of ridge collapse is not going to affect us too much. And even if it is to a point that we do need to do some secondary grafting, it's going to be very minimal and very predictable. So we can graft in a lot of different ways, and this just kind of shows you, just right off the bat, before I even get into the products that I use, shows you that you can have a huge improvement in limiting vertical and horizontal resorption by using a graft material. And this is a benefit, as I said, for the patient, but it's also a huge benefit for you as a practitioner, because I don't know about you, but I would much rather have a nice, easy 15-minute single implant placement than an hour-and-a-half long placement and graft and having to use a membrane and potentially having to use tenting screws. And it really then starts to become complicated. And the more procedures that you add into any major procedure that you're doing, then it becomes more like a house of cards, that all it takes is for one of those things to go wrong during the healing process, and then the whole thing becomes affected by it. So what we need to start out with is, when we have a tooth that is treatment planned for extraction, you really need to look at getting it atraumatically extracted. And what I mean by an atraumatic extraction is that we want to cause minimal disruption of both hard and soft tissue. By decreasing the amount of disruption, we decrease the amount of overall inflammation. That will then decrease the amount of remodeling that occurs, and will not force the body to try to change the topography of what we currently have. And we're always trying to protect that buccal plate or facial plate, because that is the weak link in this whole structure. So we can do this with a number of different things. And some of the instruments I'm not really going to go into much on atraumatic extraction, but things that I do like is I like to use peritones, especially in the anterior, in order to get down, cut the periodontal ligament up at the top of the crest, get that soft tissue separated, give myself the ability to get in with my next instruments. I love nice sets of luxators. Those work really, really well to get down in between the root and the alveolus, get that tooth moving, taking my time, and then I can come in with either a set of atraumatic forceps, of the standard variety, or use something like a physics forceps in order to get out the tooth without damaging the hard tissue that's around it. And again, that's the goal, is to get this tooth out with the minimal amount of disruption, and therefore we're going to have a much better chance of minimizing the dimensional changes that are going to occur. With atraumatic extraction, some of the things that I believe in and that I try to do all the time is I want to use slow, forceful movements. I don't want to rush. When you rush and you move quickly, you have a tendency to fracture teeth off. Then that just makes the extraction process much more difficult. If I'm using conventional forceps, I'm going to use a lot of rotational movement, especially with single rooted teeth. I'm using the shape of the root to expand the alveolus, expand the socket, make it easier for the tooth to come out. Multi-rooted teeth always section, especially if you have dilacerated roots, large roots, endo-treated teeth. You're just going to make your life a lot easier by sectioning these things first and then coming back and removing them as single rooted teeth. And then overall, just be patient when you're taking teeth out. Again, take your time, allow biology to work, allow collagenase to help you out by starting to dissolve and break down the PDL. All these things are going to help make your extraction go smoother. So when we do remove a tooth, there's this cascade of events that happens. Now, this happens whether you graft a socket or whether you let it heal naturally. On day one, we're going to get that socket. It's going to fill up with blood. You're going to get a fibrin clot that's going to occur. That's going to kind of set the motion for the rest of the healing. Within the first few weeks, we're going to start to get new growth of blood vessels or angiogenesis. This is going to happen around the same time that we're going to hopefully see soft tissue closure, by about 2.5 to 3 weeks. And then from there on, we start to get new bone formation. So now we have, excuse me, we have osteoblasts and other cells that have come into the site. They're disorganized. They're starting to establish themselves. By about a month or so, we start to get the beginning of mineralization, and we get the conversion from osteoblasts moving towards adult bone cells or osteocytes. And then by somewhere around 6 weeks to 4 months, we're going to see reorganization into cortical bone and cancellous bone, and we should be able to have a site that's regenerated by about 4 months if we don't do anything at all. Now, the thing is that all graft materials work, and everything can work and everything does. Anybody who tells you that graft materials don't work, is not really giving you the full story. But there are differences between different materials that are out there. And so when we look at the ideal graft material, what would we like if we could wave a magic wand? I want collagen because it's going to help with cell binding and help with the bone formation. I need a reservoir of mineral that's going to provide at least calcium, but we're going to want phosphate. We're going to want some other components also. And then one of the really important things about graft material is that it needs to break down at about the same speed that we're getting apposition of new bone. If we get breakdown too quickly, then we're going to have connective tissue. We're going to have incomplete growth of bone. And if it lasts too long, if it's too hard to break down, we get the opposite. The body tries to break it down, can't do it, has a tendency to encapsulate, and then we again get a high percentage of connective tissue with encapsulated graft material. So, ideally, there's something that we're looking for, and different materials out there provide 1, 2, or maybe 3 of these things. What our goal is to regenerate bone, not to repair it. If we regenerate it, we're going to have a structure that is going to be stable. It's going to be a perfect host for a dental implant, and it's going to not want to change so much over time. Now, grafting materials, there's a lot of them out there, and I'm quickly going to go through this. We can get bone from the patient, host bone. We can harvest that intraorally. We can harvest it extraorally. We have allograft materials, which are come in 2 different kinds of varieties. We have mineralized and we have demineralized versions of it. We have cortical, we have cancellous versions. So there's different styles that are available. There are xenografts that are out there that are animal-based. Bovine bone is the most popular, has been around the longest. There are porcine products that are starting to come on the market or have come on the market in the last few years. And then we have the largest category of bone substitutes or graft materials, which are the alloplasts. And there's a lot of different types that are out there. And then you see in the center here, you see OsteoGen. And OsteoGen is a category of its own. And we'll get into the reasons why it is very different from all of these other products. Now, quickly, autogenous bone. Always been the gold standard. It does everything for us. We get good bone in about 3 to 4 months. Problem is that you have to get it from someplace, and that's that second site morbidity. In dentistry, we're seeing less and less autogenous bone being harvested. We are seeing the use of other bone substitutes to a higher percentage, and we have been seeing that for at least the last 20 years, and I think that we're going to continue to see that as we move forward. Allograft materials, cadaveric and based, as I mentioned before, again, 3 to 4 months in turnover, and it really, success is dependent on the type, cortical, cancellous, mineralized, demineralized. All of these will affect how these products work. And then kind of a downside to allografts is that the cost seems to be creeping up every year. And that is due to the way that it is processed, the way that the donors are collected. So we're probably going to end up seeing the cost continue to rise as time goes on. The other problem with allografts and even some xenografts is the fact that we can get a lot of connective tissue that occurs in these sites after they have healed. And where this happens is that the bone is unable to be broken down, or the particles are not able to be broken down, and they get encapsulated by connective tissue. And then that connective tissue then never really goes away. And it can be very high in some cases. This is just a number of studies that have shown this over time. There are a whole handful of studies above and beyond this that will confirm this. And we're going to touch on this in just a little bit more on why this happens. And then we've got xenografts. These are the animal-based products that I mentioned before. They take a long time to turn over for the most part, more than 6 months. I remember when I was using bovine bone as a graft material, and I would come back in 6 months on an extraction site and get ready to place an implant and open up the site and to my dismay, would see particulate still there. I'd see some bone, I'd see a lot of connective tissue, and I would see chunks of particulate, and that's not what we really want when trying to do implant treatment. There are incidences of inflammatory response that can occur from these products. We can have religious issues with some patients, especially with bovine bone and even with porcine bone. And there is an incidence of late failure and foreign body reactions, which have been documented mostly in the orthopedic journals, but have also been documented in many of the dental journals over the years. And then we come to the alloplast materials, the man-made materials, so to speak. As I said, many forms available. The thing is, it can be unpredictable. Some work really well, some don't work at all, some work semi-good. I've had, for the most part, historically, I've had, 50-50 with my success with some of these materials. This is probably due to the fact that some of these materials resorb way too quickly and some of them never resorb. And, to show you an alloplast material, this is Bioplant. For those of you that can remember when Bioplant was the hottest thing on the market, this was very early on in my career, and this is 9 years post-op, and there is still graft material there. That is not turned over. It's been encapsulated. There is vital bone around it, but you drill into a site like this, it's like popping a beanbag. You get all these little HA ceramic coated balls that start coming out. It makes it very difficult to get a nice concentric osteotomy, and then down the line, this is not going to provide bone to implant contact, and so we could have issues once that implant is loaded. So when I see something like this on an X-ray, or I see a very radio opaque area on an X-ray, it makes me question and wonder what is going on and whether there is vital bone there. So, as I said, this encapsulation can become a real problem. And I believe that encapsulation is one of the things that contributes to failure after loading. 6 months down the line, 2 years down the line, 5 years down the line, the pressure and the mechanical movement of mastication against connective tissue is not going to be as good as a bone to implant contact that is very intimate. So these are things that I think about all the time, and things that I worry about, and I look at failures that I've had in the past and try to figure out why those things happened, and maybe this is the reason why. So we're going to be talking about composite grafting plugs. And before we get into the specific one that we're going to talk about for this webinar, I just want to give a warning shot out there that just because a plug looks like a plug, it does not mean it's the same thing. And on the market today, there are a lot of products that are carbonite apatite plugs. And the majority of them are made by a single company, and they are private labeled for a number of different ones out there. They are carbonate apatite mixed with bovine collagen. They usually have about an 80-20 ratio. And so this ratio is very high. And carbonated apatite is a unique molecule or particle on its own. These characteristics that we see with these plugs is, number one, they have a tendency when they get rehydrated to get kind of, for lack of better terms, gooey, and they kind of fall apart, and the particulate separates from the collagen, and it makes it really hard to keep it all in place. Often a barrier is necessary, and then the resorption time is very long. It can be up to 9 to 12 months for these materials to resorb, and we'll get into the reason why here in a moment. It takes so long to turn over because all of these products are sintered. And a sintered product means that it is subjected to high heat at some portion in the manufacturing. And when we take hydroxyapatite and we heat it up to a higher temperature for a period of time, we essentially turn it into a ceramic. And ceramics are very difficult for our body to break down. And the other thing that happens is these molecules then are changed, and they hold on to their components very tightly instead of basically sharing molecules or sharing ions. The ions want to stick and hold tightly to this carbonated apatite. They create this sintering creates a bigger molecule. It helps with the way that the molecule can withstand forces, but it makes a bigger molecule. And then It does have calcium and phosphate, but what it does is it substitutes phosphate, gets connected to it instead of a hydroxyl group. And this is a really, really key point, because hydroxyl groups are really necessary for not only the environment for new bone growth, but also for this particular or any grafting material to become accepted and to be used by the surrounding bone to regenerate new bone. If we kind of look at it, this is just an example of a carbonated apatite plug on the left. This is the Implant Direct Osteo Plug. You can see that the collagen is a little fluffier compared to the OsteoGen Plug on the right. When we look at a X-ray diffraction of these two, we've got the carbonated apatite on the left, and we have the OsteoGen Plug on the right. You can see that the size of the particles is much larger and much denser in the carbonated apatite plug versus the OsteoGen Plug, where it's a more uniform distribution of smaller particles. There are other plugs out there that you might run into. Foundation has been around for quite a long time. Straumann Regenemer has been out for a little while. These are not really graft materials at all. There's no graft material, no mineralized graft material in here. Essentially what they are is cross-linked collagen. It's what's called a telocollagen, and it basically is a binder. It's a binder for cells. It's a clot former. That's pretty much all it really is. So it's not really a graft material. And then there's xenograft-based plugs, BioHorizons, ACE. They both have them. They're about 80% bovine, 20% collagen. Again, no different than other xenograft-based particulates. They're going to take more than 6 months to turn over, and that's because most and almost all bovine bone is sintered at some point to decrease the antigenicity of the particles. Geishlich BioOst collagen, again, 90% bovine bone, 10% collagen. These are extremely dense, and according to the instructions for use, a barrier is required with these plugs whenever used for grafting a socket. So they're very different products, and we're going to see the contrast to this in just a moment when we talk about the OsteoGen Plug. So all I ask you is to know your materials. The more you know about these things, the better you're going to be, the better you're going to be able to choose the right product for you. So I'm going to dive into some science here, and then we're going to see some cases, and it'll hopefully create a full story that's going to make sense for you guys. The OsteoGen crystals are unique. They are bioactive, they're biomimetic. What I mean by that is bioactive is that bioactivity in two ways. They are bioactive in the fact of how they create an environment that is conducive for new bone growth, but they also are bioactive in the fact that the combination of collagen and the OsteoGen crystals, when compacted into a site, create a sort of pseudo barrier that prevents fibroblastic infiltration, and we're going to see a little bit more about that in just a moment. The crystals are biomimetic, meaning that they look and they behave very much like native bone, and that makes for again, bone growth that is going to be slightly accelerated at the start and is going to be more complete when we get done with the healing process. These crystals are low density and highly microporous. The calcium phosphate ratios are about 60-40, which is similar to human bone. And these crystals have been used clinically since 1984 for sinuses and ridge augmentations and periodontal defects. As I said, they're bioactive. They're bioactive, number one, in the way that they contribute ions to the site. Number one, they're going to contribute calcium ions. This is going to help with that conversion from osteoblasts to osteocytes, starting that mineralization process. and then be a storehouse for continued mineralization. Provides phosphate ions, which are needed in order to kick off the signaling pathway that's going to differentiate cells. It's going to help influence the action of the osteoblasts. I already stated about the collagen crystal mix preventing the downgrowth of epithelium or fibroblasts, and then those all-important hydroxyl groups, as I was talking about. One, it's going to help with the exchange of ions back and forth between other cells. And then also very important, it's going to create an alkaline environment, which is necessary for continued mineralization of new bone. You can see an OsteoGen crystal here on the left. This is a photomicrograph. We see it's very similar to laminar bone. The crystals are not particulated, so they're not grown as a big particle and then broken down to get a 250 to 850 micron. They are actually created as individual crystals. These individual crystals are 80% calcium phosphate, 20% monatite. Those are two different density calcium phosphate materials, and together create a very, very conducive environment for regenerating bone. In the composite materials, the plugs, the strips, the block, we have these crystals which are bound up in collagen. And this is obviously a artist rendition of what this looks like. And this is what it looks like under intense magnification, where you can see the crystals embedded within the type 1 bovine collagen. The science behind this has gone back years. I mean, if you're looking here from 1992, Richie did an incredible study where they created this titanium, chamber model, and then they started to see how bone would grow into these chambers with different types of materials in there. And essentially what they showed was that the OsteoGen promoted new bone growth better than any of these other materials. They showed that the OsteoGen crystals would get directly attached to the new bone without an intermediary encapsulation, which is really exciting. And then they saw dissolution at around 12 weeks. That they started to see these crystals that over time were breaking down slowly, releasing the mineral portion and the phosphate and contributing the hydroxyl ions in order to help the new bone to grow until eventually these crystals are fully resorbed. Gans did some work on it also, again showing that this was a unique product in the fact that bone grew directly to the surface of these crystals without any kind of encapsulation. A few years ago, Jones did an incredible study where they took different substrates. In this case, they took collagen, an OsteoGen material, xenografts, and allografts, and then they seeded them with osteoblasts that had bioluminescent markers on them, and then allowed them to proliferate over about a 10-day period. And what they saw was that there was a very big difference between the growth that you saw on the OsteoGen product versus a xenograft, which you can see here at the bottom of that column in material 3, that there's almost no osteoblastic growth. And then we do have decent growth on allografts and on the baseline, which was collagen. What this study showed was that, this highly porous material had the highest biocompatibility of all of the materials that were out there. That overly dense materials or sintered materials actually slowed down osteoblastic proliferation initially, and then as opposed to the OsteoGen, which started really quickly. And then also OsteoGen had the highest production in those cells of what is called osteonectin. And what osteonectin is it's a protein that basically closes off spaces in remodeling. And with type 1 collagen, it creates this extracellular matrix, and was really, really an exciting. They weren't looking for it. It's something that came about, and I think it all just suggests how bioactive this material really is when it's in the body. So we're going to be talking about the OsteoGen composite plug. Hopefully many of you guys have tried this product and have really had some good experiences with it. As I said, these products are a mix of type 1 bovine collagen mixed with OsteoGen crystals. The complete composite graft line has slim plugs, large plugs, extra large plugs, small strips, large strips, and then there's also an OsteoGen block, which can be used for larger defects. So the advantages are that in the majority of your socket preservations, you're not going to need an additional membrane. It's not going to be needed because as that collagen and OsteoGen crystal matrix is compressed into the socket, it's going to create a barrier. It's going to allow soft tissue to creep across it and to heal without diving down. We don't have to rehydrate or hydrate the material. We don't have to mix, just like we would have to do with a particulate. We don't have to worry about migration of the graft material. So we're not having to have something additionally like a collagen plug or a barrier membrane in order to prevent particulate from being lost. And I think that the biggest thing for me was that it's very easy to see when it's turned over. It starts off radiolucent or relatively radiolucent compared to the adjacent bone. And then as it gets turned over in 4 to 6 months, 3 to 5 months, somewhere in there, you're going to see a change in the radial opacity of the socket. And that allows you to check whether you have regenerated bone or not just by a simple periapical radiograph. So with traditional socket grafting, you're going to extract, you're going to graft the area with a particulate, then you got to contain that graft with a plug or a membrane, and then suture everything closed. With OsteoGen plugs, it's a little bit different. So what we do is we start, as I said, with an atraumatic extraction, and then we need to get bleeding. It's extremely important with this product to make sure that we have active bleeding coming from the socket. And we'll talk about some techniques to get that in just a moment. And then what you're going to do is you're going to take your OsteoGen plug, and if you need to cut it to size because of the diameter, then you're going to place it into the socket and then slowly allow that active bleeding to flow into it. As it flows into it, it's going to become more malleable and more compressible until you get it all the way down to the level of, it doesn't have to be down at the level of the crest, it can be a little bit higher, that's not a problem. And then what you're going to do is then you're going to suture it. Simple figure 8 suture works very well over the top of this. And then we're going to go ahead and give our patient post-op antibiotics, whatever kind of pain meds of your choice. And then we will go ahead and allow things to heal. We'll have the patient back in about 2.5 weeks for suture removal. During that time, soft tissue's closing over the top. And then we should have turnover of bone at about 3 to 5 months. We should be able to place an implant in there. The site won't be 100% turned over, but it'll be turned over to an extent that you'll be able to get good primary stability, and then the site will continue to heal as the implant is healing in place. All right, so as I said, when we place this material, it looks very radiolucent, and then in about 3 to 5 months, you can see the change. And that is, like I said, very easy. And in the protocol in my office is to bring the patient back, do a periapical. Hey, this looks good, looks like there's bone. Now I'm going to end up doing a CBCT to verify my bone volume, get all my dimensions for my implant, and then move forward with my implant surgery. As I said, we need bleeding, and the key to all this is regeneration. What we're doing is we are tapping into something that's called the regional acceleratory phenomenon. What this is that we need to create a little bit of damage in order to cause the tissues to start to heal. And so what we're going to do is we're going to get that tooth out. We're going to make sure that there is adequate bleeding. That's going to be done in a number of ways, and which I'll show you in just a second. But we need to have bleeding. One of the biggest mistakes that over the years, and I've been teaching this product since 2014, that not getting enough bleeding is where you get results that you're not really happy about. If you can get good, adequate bleeding, then the plug does its job, and between the plug and the body will regenerate. So what we're looking for is we're looking for profuse bleeding. And so here we have a tooth that's going to come out. As I said, the first thing we're going to do is we're going to section this tooth. Makes it easier to get out, when it's two single-rooted teeth. We go ahead and remove that tooth. And then one of the ways that I can get adequate bleeding, first I go in with a standard curette. That may work. If that does, great. If not, these are degranulation burrs. They come in various sizes, very coarse diamond on them. You run them nice and slowly up and down within the site. We go ahead and have the assistant suction and then let the site fill back up. And this is what we want to see. We want to see blood that is actively coming out from the socket. And these burrs do a really nice job. Another instrument that works very well are serrated curettes. You can get in there, really scrape up the walls, create bleeding points. If neither one of these are working for you, then a 557 long shank surgical burr, poke a couple holes through the lamina dura, get some active bleeding. That's going to assure that your OsteoGen plugs are going to do their job. So as I said, we're going to extract atraumatically, put a dry plug in there, hold it in place with a figure-8 suture. About 2.5 to 3 weeks, we're going to follow up, remove the sutures. By then, soft tissue should be healing pretty well. And then we're going to reevaluate in 3 to 5 months, depending upon the patient. If they have medical issues, systemically they're compromised a bit, we might end up being more towards that 5-month mark. Majority of the patients are going to be somewhere between 3 to 4 months where you're going to end up seeing them again. And then again, taking just a check PA in order to figure out where you're at. So, again, no need for membrane in most cases, but if you have hard tissue that is deficient, you have a dehiscence, you have a loss in vertical height, usually on the facial, then you're going to want to go ahead and graft with your OsteoGen plug, but then you're also going to want to incorporate a collagen membrane in order to kind of use a belt and suspenders approach to assure that we're going to get a good outcome. Again, we kind of talked about things earlier. Here, this osteopontin stabilization is a binding agent, and it limits the open spaces. So again, this is what prevents a lot of the downgrowth of your soft tissue. All right, so they checked this, they showed it. They showed that when you use a highly ceramic hydroxyapatite or a sintered hydroxyapatite, you actually have a delay for the first 5 days of soft tissue closure. And they did not see that when using the OsteoGen material, especially when it is combined with a collagen. So we get a rapid closure, like I said, usually within about 2 to 2.5 weeks, we're seeing closure on this. And for ridge preservation and with guided tissue regeneration, this material works extremely well. This is a recent study that was done by Irina Dragan, and it really showed how well this material works in a complex case, or a case that is not just a simple extraction with a 5-wall defect. So let's see how this all works. Here we got a number 18 that needs to come out. We atraumatically remove the tooth. We're going to go ahead and degranulate and clean out the site, get adequate bleeding. And then what I'm going to do is I'm going to take my plug, and in this case, the top broke off. That was my own fault. But what I do is I take a suture scissor and I cut it up the center from the tip and create 2 roots. And then what we can do is we can place that down into the socket. One side goes into the distal root, one side into the mesial root. That second piece that popped off goes right down on top of it. We pack it in. And then once it's packed down and blood is soaked into it, now we can secure it with sutures. You're going to see a lot of these cases where I used chromic gut suture. That was just due to the situation at the time when I took some of these photos. I was traveling from office to office, and some of the docs that I worked with didn't want to do suture removals, and so they asked specifically for something that was going to resorb. For the most part, within my own practice, I use non-resorbable suture, or I use Vicryl, and then bring that patient back for that 2.5-month follow-up, or 2.5-week follow-up. All right, here's another case. So again, another number 18. We've got defect on the distal, granulation tissue. We're going to go ahead and get this tooth out, and then we're going to clean all of that defect up. Now, if I was missing a buccal wall, or I had a defect on the buccal, then I would go ahead, do a full thickness soft tissue elevation, reflect off the defect. I would place a collagen membrane down there, place my plug, and cover everything back up. In this case, we had intact walls all the way around, so all I'm going to do is clean out the granulation tissue, get nice adequate bleeding, and then deliver my plug dry. You can see the plug here has been delivered, the blood is soaked into it, and now we just need to confine it with a figure-8 suture with and I like to do a single interrupted over the top, and this shows you a real good picture of what that suture does, how it holds that plug in place, and now allows the soft tissue surrounding that socket to start to creep across. And like I said, by about that 2.5 to 3 week period of time, we should be seeing just about complete closure on this. And this is what it looks like. This is OsteoGen Plug material in the socket. You can see here it's less radio dense than the adjacent bone. And what we're going to look for when this patient is ready in 3 to 5 months, we're going to look for the radial opacity in the socket to be equal or pretty darn close to that radial opacity that we see on the bone mesial to the socket we just grafted. Here's number 19. So we've got a little periapical lesion here. I'm always asked about these. We're going to go ahead and get this tooth out, and once we get it out, hopefully we've got the cyst that's going to be stuck on the end of that root. If it's not, then we're going to get in there. We want to curette that all out, clean it out really well. We may go down with a degranulation burrs to clean it out also, and then rinse it out with sterile saline really well. So here we've got the tooth. We're going to go ahead and section it and get it out. And now we've got our 2 bleeding sites. We're going to, again, make sure that we get that mesial root cleaned out really well. And now we're going to take our OsteoGen plug. This just shows the packaging on it. We're getting adequate bleeding. And then I cut my plug. I just cut it about halfway up the center. I now have a mesial root and a distal root. And then when I have infection that may be going on, short of purulence, if I have purulence, I'm not going to graft. But if I have an infection and I'm not 100% sure that I've cleaned it out, sometimes I will use a topical antibiotic, and I'll drip it onto the plug before I deliver it. My go-to these days is gentamicin sulfate. It's an ophthalmic solution of 0.3%. You can get this through your supply house. It's a dropper bottle, so it's really easy to use. You just basically put a drop or two onto your plug and then set it into place. We're still going to follow up with systemic antibiotics afterwards, but this is kind of, again, give us kind of a 1-2 punch to fight any infection that's going on in there. Here we can see the plugs being compressed down into the site. We're allowing the blood to soak into it slowly, and as you do that, you're going to feel the plug kind of compress. Once it starts compressing and the blood is completely saturated it, now we can tamp it down. We want to use a bone plugger or the back of a periosteal elevator to keep it, to push it down. And then we're going to, again, do a figure 8 suture with an interrupted, clean off any excess, have the patient bite down on gauze, regular post-op instructions, antibiotics, and post-op medications for discomfort. Here's a tooth number 2. This is a very, very common situation. So this patient's going to lose this tooth number 2. Their intention is somewhere down the line, they want to get an implant. And if we look at this radiograph, we can see that we already have a sinus that's pneumatized. I will guarantee you that if we take this tooth out and we don't do any kind of grafting at all, that sinus will continue to pneumatize until the point that we have just a few millimeters of crestal bone to work with, which then would require, if this patient wants to have an implant, possibly and more likely a lateral sinus lift. I don't know about you, but doing lateral sinus lifts in a second molar area is not a whole lot of fun, especially when you have a first molar there in front of it. So we want to try to prevent that kind of pathology from happening. And all maxillary teeth are susceptible to more change than we would see a lot of times in the mandibular arch. And that's because we have both the sinus and we have bone remodeling happening at the same time. Basically, we have resorption coming from both ends. And so what we want to do is we want to minimize that. So here we've got that tooth. It's a multi-rooted tooth. We're going to section it first. Once it's sectioned, then we will get the individual pieces out. And then we'll go ahead and clean the site, get nice active bleeding. Once we get nice active bleeding, now we're going to take a plug. I'm going to cut 1/3 of it lengthwise. That's going to go down into the palatal root. And then I'm going to take the rest of that plug, cut it up the middle. This is going to be for my mesial buccal and my mesial distal roots. We'll go ahead and get everything in, pack everything down nice and firmly, and then suture over the crown, top of it. So here we've got the suture over the top. We have the patient bite down on gauze, all the normal post-op instructions, and we go ahead and send them off. This is what it looks like immediately post-op. Again, radiolucent, doesn't look like, it's got a little more radial opacity than just the socket, but it doesn't look like a whole lot's in there. But you can see that it's definitely different than bone. And we have the patient back at about a month. There's our soft tissues fully closed. We're now just going to allow the keratinized tissue to continue to grow. That's going to fill in that defect, and then underneath that, our bone is regenerating. And here we have that same patient at the 4-month mark, and you can see here that we have maintained bone that if we want to place an implant in this second molar region, we're going to be able to do it and be able to avoid having to do a lateral sinus lift in order to facilitate that. Here's number 19, just another one showing you non-restorable tooth. We're going to section it, get it out. So there's our socket. Again, we're looking for nice continued bleeding. This is the reason we section teeth, because otherwise trying to get this thing out in one piece, more than likely that curved root tip would probably have broken off, and then you would have spent 45 minutes trying to get it back out. OsteoGen Plug. Again, cut it up the center. Now we insert it. So you can see here, it's going in dry, starting to soak up the blood, and we give it a little bit of time, and now we've got a fully saturated plug, sutured, and regular post-op on that. And then another view from the lateral side. Failing bridge, got a first bicuspid and a second bicuspid, which need to come out. There it is intraorally. Extract both teeth, get good bleeding. And now this is where a plug can become very economical, because now we can take one single large plug, cut it straight at the middle, and we now have graft material for 2 single-rooted bicuspids. There's in the second molar, or second premolar, first premolar. Since the papilla tore in the center here, I'm going to go ahead and put a single suture over that, just a micro suture. And on this case, instead of using a figure 8 suture to seal everything up, we're going to go ahead and use some periacryl. So the high viscosity periacryl, which is the purple material, comes in little preloaded ampules. You cut the tip off, break the tip off, and now you've got a little bit of material in here. And then what we do is we seal the site. So what I do is I take that periacryl and I cover the top of the plug and the edges of the wound. We do a very gentle water spray over the top of that. That sets it. We'll do 3 layers on it. So there's just another view. And here we are after all 3 have set. And then regular post-op instructions for this patient. Over the next 2 weeks, that material, that set periacryl is going to go ahead and start to slough off. We bring the patient back in a few weeks and we take out that suture. Here is at 2 weeks. You can see we've already got epithelialization. Plugs are completely covered. And we saw him again for whatever reason a week later. I think we actually took an impression for his partial framework at this point. But you can see these sites are just a few weeks away from being soft tissue, fully healed. And underneath it, the bone is continuing to heal and will take 3 to 5 months for things to turn over. Same thing, again, here's another one, tooth number 10, atraumatic extraction. Using rotational movement, we were able to get this out without that tip breaking off. Again, half a plug, or if you use the slim plugs, you would use a slim plug in this situation. Introduce it, allow the blood to soak into it. And then again, we're going to seal this site with the periacryl. The site is sealed up. We're good to go, and patient's dismissed. And here it's back at 2-week post-op. So we can see epithelialization is already covered our graft site, and now everything else is going to heal nicely underneath it. So the OsteoGen composite graft plugs they're extremely efficient. In my hands, they have been very predictable. They're extremely cost effective for you because you're not having to use an additional membrane in most situations. The key is going to be get adequate bleeding. That is going to be the first thing you need to do in order to assure success. If you've got a defect in the hard tissue, use a membrane, whether it's collagen membrane, PTFE membrane, whatever your membrane of choice is. Make sure that you're suturing securely if you're doing that. You want to make sure those sutures are going to continue to stay in there for at least 2 weeks and hold that plug in place. If you're using the periacryl, then that's going to do it. Make sure that it's not only connected to the plug, but also the tissue on the sides. And then we're going to reevaluate. Again, after the post-op in 2.5 weeks, we're going to reevaluate in 3 to 5 months radiographically, determine what our next step is going to be, and move forward with either our conventional implant placement, or whether we're going to go with a fixed bridge, or we're going to go with a removable appliance. Your choice at that point, but it's nice to have options. It's nice for the patient to have options at that point, and then you can move forward with treatment. Okay. If you guys have questions above and beyond or beyond this webinar tonight, please feel free to reach out to me via email. I'm very good at getting back to you relatively quickly on things. You can ask grafting questions, you can ask materials questions, whatever you need. I'm here to help you guys out. So I hope to hear from some of you guys. And with that, I want to say thanks, and I'm going to turn things back over to Lauren.
Thank you very much. Don't go anywhere because we do have some questions. But as
Yes.
I mentioned at the top, a couple of things. So I know some of you probably logged on a little bit late. This webinar was recorded. The recording will go out sometime in the next few days, so keep an eye out for that. As far as the CE credits are concerned, there's literally nothing you need to do. We track when you logged in, when you logged out. As long as you were here for most of the webinar, you'll be sent that CE certificate. There's no registration or test or anything like that. Before we get to the Q&A, though, as I mentioned at the top of the hour, these webinars don't happen unless we have amazing sponsors like GoldenDent, who are bringing in the speakers and helping to develop the content. So I'm going to briefly turn things over to Kurt Lawler. Kurt is going to talk about some of the specials that they have, which we always want to make sure that we say thank you to all of you for joining here. They typically offer some very nice limited time specials. So I'll let Kurt take that over, and we'll and then get to the Q&A. Kurt, take it away.
Lauren, thank you. Appreciate it. Like Lauren said, this is Kurt from GoldenDent. We're a third generational dental family based here in Detroit. We started with the physics forceps many years ago now, and we look for simple, predictable, and unconventional type products. And we've had the OsteoGen Plug for a number of years, and we've always known it's an excellent product, and we've shown it many times through various presentations. And I hope tonight a little bit more of the scientific background on it explained a little bit further as to why this truly is the best plug on the market. So I'll mention the promotional offer just here quickly, and then go through a few slides so I can save some time for some questions. But golden-dent.com is our website. If you're not currently using the OsteoGen plugs, or you're just looking to stock up, the deal for this evening is going to be 15%, and the promotional code is GOLDEN15. So it's just GOLDEN and then numeric 15. And then that does exclude like the 5+1 offers. We always get that question, you know, why isn't the code working? It will not work on the if you add a promotional item and try to add the additional promotion on top of it, it won't work. But this will work on anything on our website, including the plugs. If you take a look at our website, or you're an existing customer and you make your way to GoldenDent, you say, hey, this looks a little bit different. If you haven't been there in the last few weeks, we do have a new website, a little bit of a different look. So I just wanted to mention that. Hopefully you find it easier to use and find things to be a little bit better organized. These deals are 24 hours, so it expires tomorrow, May 6th. And we went over this in good detail. If you aren't already using the plugs, the large size is absolutely the most popular size of plug. You can cut the large size into 2 plugs, as was shown, and make it into slims. Extra large is really not very popular for us. So if you haven't tried the plugs, I would just start with a box of the large size. It's going to be the most used in your office if you're not currently using them. This is just showing the plugs. We showed this in great detail, so I'm going to skip this. So as mentioned, bleeding is very important. So we do have a full line of grafting instrumentation. We have conventional allograft and membranes if the case may require that for some more advanced type cases. But we do have a nice rated curette if you're looking for something that will would allow you to clean out the socket site and generate some bleeding for proper use with the OsteoGen plug. We do have an affordable serrated curette if you're looking for one of those. We have a simple graft kit too. So maybe some of the attendees this evening aren't doing any grafting. OsteoGen Plug is a great way to get involved, and maybe you want a simple graft kit where you can keep everything together. We have a really affordable kit here, and if you do order this kit or are looking into this kit and you're more interested in the serrated curette, please let us know, because we do swap that out for the regular curette that comes with the kit normally. Now, sometimes the serrated curette, as was mentioned, you can use a burr, but we do have some nice tissue and degranulation burrs too that'll allow you to degranulate the socket site or to create a little bit more bleeding. That's just another option if you're having some issues with trying to manually create that bleeding socket site. Sutures, of course, you're going to need a suture. If you're using a PGA type suture, or if your preference is like a black silk or chromic gut, we recommend probably the PGA one here. Take a look at ours. There's a lot of different PGA sutures, but ours are a really affordable option. So just real quick, what's new? I just wanted to mention, if you haven't got one of our emails in the last month or haven't been to our website, we just launched a new brand of single-use diamond burrs that we're pretty excited about. Take a look at those if you get a chance. And then the zirconia burrs are also back. We've had these in the past, and we found one that's even better. We have them in stock, and they're ready to go. So zirconia is always a challenging thing to remove, and we have some new zirconia burrs that are very excellent. You'll find them on our website now. Lastly, this is totally off subject, but I just want to mention we have a new Smart IPR system. These are really nice. They allow you to kind of twist the barrel at the top and change the shape of the strip. It's like a twist type feature. Comes with a handle, and if you're using a system like this, you'll find that ours are going to be very competitively priced. Lastly, if you want to take a class or get more involved in grafting, or you say, I'd like to use the plugs first, we've offered live patient extraction and grafting courses for a number of years, where you can actually extract the tooth on live patients and place the OsteoGen plug. So that's a really great opportunity to take a look at the plugs or get a little bit more in-depth experience with suture and grafting, maybe flapping, or even just extracting the tooth. So these are some of the next dates we have coming up. We've done AMP1 and AMP2 Plus for a long time, and then backed by, I guess, popular demand, we've had a lot of people asking, when are you going to bring the endo class back, and then your full arch reconstruction class? So I just wanted to mention it while I have some existing customers on the line this evening. AMP5 and AMP-E are back, so take a look for those dates in the fall. And then lastly, our next webinar, we're going to do a different subject. We're going to be talking about air polishing and scaling, and in a webinar maybe a little more focused for the hygienist, and that one's going to be June 23rd. So look for an invite and a registration link with the follow-up email after this webinar. That's it for me. I'll leave this on the screen and turn it back for the questions. Thank you.
Thank you, Kurt. We appreciate it. And I would encourage people, having worked with GoldenDent for over 10 years, they mean what they say and they say what they mean. So 24 hours means 24 hours. If you call them up on Monday and say, hey, I'm ready for that deal, it's not going to be available. So I would highly recommend. But Chuck, we got some questions for you. You ready to roll with it?
I'm ready. Let's do it.
Let's do it. Let me just see. Are there any indications or contraindications to combining graft materials, like maybe like allograft in the socket and then xenograft outside the socket?
No, I mean there are a number of different, I guess you call them sandwich techniques that are available out there. I think what you have to look at is number one, what are you trying to accomplish, and why are you looking at using different materials? Is it because you want different resorption times? is excuse me, that's usually the main reason why somebody will. Like they'll do a sandwich technique where they'll use something that might resorb a little bit faster within the defect, and then use something on top of it that takes a little bit longer to break down in order to act as almost like a Band-Aid. I see nothing wrong with that. We have some doctors who really like particulate, and they will use particulate for certain grafting situations, and then actually use a compressed OsteoGen plug on top of it as the barrier that actually will grow bone. So they kind of get the best of both worlds in their mind. So no, I don't see anything negative about that. You just need to remember that whatever material you are going to use is going to have different types of resorption profiles, and is it going to be something that you want, or that that's going to facilitate the result that you are going to want.
Got it. Okay, so why would you choose the OsteoGen over human bone allograft? You know, what's the main reason that you would go that route versus human bone?
You know, for me, it's number one, that I don't have to worry about containing the particulate. That's number one. That helps. I use the OsteoGen products, the composite graft products, for not only socket preservation, but I use it for grafting the gap around mediate implant placement, vertical sinus lifts, lateral sinus lifts. I use it for a lot of different things. About the only thing that I don't really use it for is larger ridge augmentations. For those, I have a tendency to use materials that are going to have a little more body to them, a little bit less compressible. But for me, this material has really replaced 98% of the other materials that I use, because I look at it not necessarily as, even though it comes in different shapes, I look at it as a graft material that comes in different shapes, and then I can use it for the specific reason I want. I love the idea that it is bioactive, that it's going to provide the site with everything that it needs in order to heal. I like the fact that it's still going to create a great framework for new bone growth. And I like the fact that we don't have to necessarily worry about the encapsulation issue, which I think is an issue that is been out there and might be the reason why we have failures that like I said, that we can't explain, and that we've used other excuses, so to speak, for the reason why, you know, you place this perfect implant, the surgery goes exactly as you liked, you know, you got good primary stability, everything was perfect, and then something happens, especially after you load it. You know, you do a stability test, everything looks great, you load it, and 6 months later the patient comes in and they're like, hey, you know what, this doesn't feel right, and you take an x-ray and things look horrible. And maybe that is something that we can attribute to this encapsulation that we don't really even think about, nor can we see it radiographically. So yeah, I like this material because it alleviates many of those problems. It's a simple, straightforward material that creates or allows me to solve my problems very efficiently, and I don't really need to think twice about it.
Okay. What about for your anesthetic? Is using like a standard lidocaine with epinephrine kind of a double-edged sword, since you said you're trying to generate bleeding into the socket, but of course the epinephrine is a hemostatic agent. So, you know, are you using anesthetic without epinephrine, or how do you deal with that?
No, I mean, I'm still doing that. I mean, for the most part, for extractions, I'm using Septicaine with epinephrine, and you know, I personally have not seen a big change in the bleeding within the socket. Yes, it's a vasoconstrictor. Yes, it's going to decrease it a little bit, but that's why I work as hard as I do to get good bleeding. I don't like using anesthetics that don't have epinephrine in them, just because of their short duration. Patients have a tendency to I don't know, you know, best laid plans go to waste, and now all of a sudden you get caught up in something else, and now you jump back into the patient you're already 30 minutes into, after you've already anesthetized them maybe, and I don't want my especially in the maxillary arch, I don't want my carbocaine to dissipate and be gone by the time I'm in the middle of my extraction. So I don't see any big difference. What I do avoid doing is I do avoid putting anesthetic directly into the extraction site. I know that there are people in the past, and I was definitely one of them at one point that used to rehydrate graft material with excess anesthetic. I've definitely gotten away from that, not only because of the hemostatic aspect of it, but also the fact that now it's a very acidic environment, which is not going to be conducive for my new bone growth or to kick off the new bone growth. So long story short, no, I don't really worry about using anesthetic with epinephrine at all when I'm using it as an infiltrate or a block or something like that.
Sure. Okay, what about using the OsteoGen for more challenging situations like a lateral window open sinus lift or a missing buccal plate?
Yeah, it works really well. Again, looking at this material as an other alternative graft material. And what I mean by that is that you cannot forget all of the rules that you follow in order to assure success in other ways. If I'm going to use it, for example, in a lateral sinus lift, I'm going to do my lateral sinus lift. I'm going to use this material as my graft material, and I'm still going to cover my lateral window with a membrane. When I'm using it for again for something that might be like a lateral augmentation, a small lateral augmentation, I'm going to do my lateral augmentation if it's large enough that I need to prevent the problems that occur with soft tissue pressures. Then I might use a tenting screw, or I might use a PTFE membrane that has a titanium reinforcement in it. So again, I look at this material as just a one-to-one exchange for particulate, but still following all the rules for the most part that particulates come with. And again, if I have a dehiscence, I'm going to more than likely undermine the periosteum. I'm going to get a membrane down in there. I'm going to graft my socket with my OsteoGen plug. I'm going to fold that membrane up over the top of it and close things up. Or I could just leave my membrane on the facial bone and then reposition the soft tissue, not worrying about the most coronal portion of the socket, because I have the effect of the OsteoGen plug to prevent soft tissue infiltrations. So I've pushed this material a lot over the years, and it's really performed well. It solves some of the problems that we run into with the particulates. For example, like an oral antral communication, where we need to, if we're going to fix that on an extraction with a particulate, we're going to need to put some sort of barrier up over that oral antral communication. Otherwise, we're going to push particulate into the sinus. Well, here I don't have to do that. I can take a plug, I can put it in there. That plug is going to seal everything up. It's not going to migrate. Schneiderian membrane is going to heal very, very rapidly across the top of it. And I'm able to solve the problem of grafting a site and repairing my perforation at the same time.
Sure. Okay. Let's see here. Okay, that's a good question. So you showed the periacral and using it on top of the sutures. What about using it in lieu of sutures? Can you get a long-lasting enough primary closure, or is that just flirting with disaster if you go that route?
No, it does. It works. On that second case, we didn't use any sutures at all. And, as long as we've got, the only reason I used a single interrupted suture on that first case was because the papilla had torn and come loose. I tried to reapproximate it. It just didn't want to. I think I lost some of the tissue at the peak of the papilla. So rather than have something that could potentially come apart and flop, I threw one suture in there. But if you've got an intact socket, and you have nice soft tissue all around it, then you can use the periacryl to seal up the site, and that will keep everything in place and allow the clot to form underneath and incorporate into the plug. And by the time that the periacryl starts to slough off, you've already got epithelialization underneath.
Okay. What about if when you extract the tooth, you notice purulence? Are you going to put your bone graft in, or are you going to close it up and wait for that to get under control before you then graft?
I'm gonna hold off. That's a great question. That's the purulence is the reason that I would hold off from doing immediate grafting or an immediate implant. And so on situations like that, we'll go ahead, extract. We will clean the site out, get the patient onto systemic antibiotics at that point, give them a few weeks. If it's a situation where we have a defect that we're going to really need to graft, then we can come back in a delayed procedure and reopen things up once the infection is cleared. I've done that also with immediate placements on implants, where we'll get the patient going for a few weeks, 2 to 3 weeks on antibiotics, or get them back 2 to 3 weeks later, infection is all cleared up, and then we basically go in, clean out the site, and start from scratch again. But definitely do not graft or place an implant in a site with active purulence.
Okay. What about combining the OsteoGen with a PRF? Are there any studies or any anecdotal evidence of you doing that?
Tons of anecdotal. There's a lot of clinicians that are doing that. The OsteoGen Plug and strips are an incredible vehicle for PRF. It works really well. Instead of using it with a particulate to create sticky bone, you're basically making a sticky plug, and it works really well. Those clinicians that are using that type of treatment are seeing all the advantages that PRF is going to give, on top of the advantage of the OsteoGen graft material.
Nice. Okay. And for implants, any preference of gentamicin versus minocycline?
I've always just been on the gentamicin. I know that there's a lot of literature out there with minocycline. It's just something that I do. I've gone kind of back and forth. Over the years, we used, a number of years back, I used to use lincomycin. I just like the gentamicin because of the convenience of application, and then again, we're gonna follow up with systemic antibiotics if we feel that we need to.
Yeah. Okay. We are right at the bottom of the hour, and we got to our questions. So anything you'd like to say before we wrap it up for the night?
No, I just want to thank you and thank GoldenDent, and thank everybody for taking time out of your evening to listen to me here. I really appreciate it. And if we run into each other out in the dental world at meetings, please do not hesitate to come on by and say hi. And I hope that you got something out of my webinar tonight, and you can take something back, some pearl back to your office tomorrow and be able to do it.
Well, thank you, obviously, very much for your time and expertise. This was a fantastic presentation. The way I'm watching the numbers, so the way that I know that it's well received is when the number of people that are on at the peak is what we have at the end, and we hardly lost anybody. So thank you, obviously, as I said, for your time and expertise. I wanted to also thank GoldenDent for sponsoring the webinar. I couldn't do this without them. And you see the code up there. I would highly recommend that if you're interested in trying these products out, you give them a call sometime, or go to their website sometime in the next 24 hours. And thanks to all of you. We know your time is valuable. I keep doing these webinars because people keep showing up for some reason. So I'm going to keep doing it. As Kurt mentioned, we do this on a pretty regular basis. Next one with GoldenDent is going to be towards the end of June. all of you who are here this evening are on the invite list and will be sent those invitations. Final reminder, the webinar was recorded. That recording should go out in the next few days. The CE certificates can take about a week or so. Nothing you need to do, no quiz, registration, anything like that. I know when you logged in, I know when you logged out. I'm going to send that off to them and they'll get the CE certificate out. But when we had close to like 250 people out of the 500 that registered that were here. So it takes a while to get all that stuff out. Please stay safe and healthy, and we look forward to seeing all of you on our next webinar. Good night, everyone.